Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can re-watch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. My name is Terry Evans, and I am a 23-year CLL patient and survivor. I'm also the director of the CLL Society Support Network. I would like to welcome you to today's event. We are joined today by Dr. Catherine Coombs, Associate Clinical Professor of Medicine at the Chow Family Comprehensive Cancer Center at the University of California, Irvine. Dr. Coombs will explain everything you need to know about biomarkers relevant to CLL and SLL, how and when you need to test for them, how knowing your biomarkers can help you inform you of your treatment decisions. And we will be answering questions from the audience at the end of this event. And we now welcome Dr. Coombs.
Hi there, my name is Catherine Coombs. I'm an associate clinical professor at the University of California, Irvine, and it's really a pleasure to be with you here today. I'll be talking about how understanding biomarkers can help guiding treatment decisions for patients with chronic lymphocytic leukemia and small lymphocytic lymphoma. So I'd like to start off with some general information on CLL and SLL, including how it's commonly diagnosed. CLL most typically is diagnosed after routine blood work shows an elevation in the white blood cell count. With any white blood cell count, it's common for a differential to be reported, which reports what these white blood cells are. And in CLL, the type of white blood cell that's elevated is the lymphocytes. And so the white blood cell count in CLL is accompanied by an increase in this absolute lymphocyte count, also abbreviated ALC. Small lymphocytic lymphoma is a bit different. So CLL, standing for chronic lymphocytic leukemia, leukemias by definition have a significant component of cancerous cells in the blood. Small lymphocytic lymphoma is the term that's used when the patient has the exact same cancerous cell, but instead of involving the blood, it involves the lymph nodes. And that's something that's very easy to get confused, but the way that myself, a CLL specialist, thinks about it is that these are exactly the same disease, but they just involve different compartments in the body. And so I like the figure that I have shared here, which is that not only does the disease involve the blood, which is most common and is required for a diagnosis of CLL, it can involve lymph nodes, it can involve the spleen, and it also involves the bone marrow. And so the way that patients present, as I mentioned, most often, this is just an incidental finding and they feel totally fine. However, some patients can come in with more advanced disease where the disease is causing symptoms. The types of symptoms that we see largely depend on where in the body the cancer is involving. And so the white blood cells themselves usually aren't causing symptoms. However, if they're crowding out the healthy cells in the bone marrow, sometimes patients can have low counts of their healthy blood cells, which can lead to anemia, low red blood cells, thrombocytopenia, that's the term for low platelets, and all the symptoms that can go along with that, such as anemia can cause tiredness, shortness of breath, low platelets can cause a predisposition to bruising and even bleeding. And so not everyone has significant bone marrow involvement. Some patients, their disease is more significant in the lymph node compartment. And so that can present with enlarged lymph nodes, sometimes an enlarged spleen. The spleen sits right next to our stomach, as you can see from the figure here. And so that can cause early satiety, which is the term that we use when you feel like you just get full really easily, and that can come with weight loss. Sometimes just the CLL burden from the blood, the marrow, wherever it's involving, can cause something that we term B symptoms, which are just symptoms that can throw off the way the patient's feeling. Another term is constitutional symptoms. And those are things like fever, drenching sweats at night. With those, we need to make sure that there's not some other cause, such as infection, which patients are also at risk for by virtue of having this diagnosis. Tiredness is also a symptom that CLL can create. That's a tough one too, because there are a lot of other causes of tiredness. And so I think it's important to exclude other causes. And then lastly, unintentional weight loss can be a symptom of the disease. But again, most people are asymptomatic at time of diagnosis, though there's always a wide spectrum in what brings patients into my clinic. So how are patients with CLL and SLL diagnosed? So CLL, it's actually pretty easy to make a diagnosis, and it can be done using routine blood testing. The lab that prompts our suspicion is this increased white blood cell count with an increased absolute lymphocyte count on the differential. But the way to then confirm that this is in fact CLL is through a test called flow cytometry that has a very typical pattern for the cell surface markers. So the markers that are expressed outside on the surface of the lymphocyte that lead to the diagnosis of CLL. Mantle cell lymphoma, a different type of lymphoma, can sometimes mimic CLL. And so in addition to the flow, my usual practice is also to send cytogenetic testing, which I'll be delving into quite a bit more, just to make sure that it doesn't have the mantle cell pattern, and then also to see then what pattern the patient's CLL is carrying, because that can inform what the future will be like. In SLL, this is essentially the same thing as CLL, but there's not a significant blood component. Typically, a lymph node biopsy would be required for diagnosis, though some SLL patients can have low levels of disease in the blood. So I've been able to get away with checking the blood, finding the low level of the cancer, even though it doesn't meet the level that is required for diagnosis of CLL. But in other cases, a lymph node biopsy is required for the diagnosis. A question that comes up a lot is whether or not a bone marrow biopsy is needed for the diagnosis. I've seen patients from the community that are told they need a bone marrow biopsy, but most of the time that's not necessary to put the patients through. And I do try to avoid it at the diagnosis stage, because we can get essentially all of the information we need from the blood testing. And so why go through a procedure if it's not something you need? Down the road, if low blood counts develop, a lot of us will consider bone marrow biopsies at that time. But in an asymptomatic patient, I personally don't think it's worth going through the procedure of the bone marrow biopsy, given that the exact same information can be found from blood testing. So with any type of cancer, it's important to think about, well, what's my stage of cancer? And so this is a chart depicting the staging that's used the most commonly in the United States, the RI staging system. It goes through 0 through 4, 0 being the earliest stage, and then 4 being what's considered the most advanced stage. RI stage 0 is the most common presentation of CLL. This is what's used for patients that have an elevated white blood cell count and an elevated lymphocyte count, as I had been talking about, but no other manifestations of the disease, such as swollen lymph nodes, spleen, liver, and the blood counts are pretty good. Stage 1 is the term when the patients also have enlarged lymph nodes. Stage 2 is the term used when patients have the white count and also have an enlarged spleen, occasionally liver, but the liver is a lot less commonly enlarged. And to get to stage 2, you don't necessarily need swollen lymph nodes. Often that accompanies stage 2, but it's not a requirement. The swelling of the liver, spleen, lymph nodes, it's supposed to be detectable by physical exam. And so this is considered a clinical staging system. So if you happen to undergo a CT scan and they find a mildly enlarged lymph node internally, technically speaking, that shouldn't get you into a RISE stage 1 based on the way that this staging system was designed. RISE stage 3 is the term we use when patients have anemia related to the disease and the CLL burden in the marrow, which is the factory that produces our healthy blood cells. And RISE stage 4 is for patients who have low platelets related to the disease burden in the marrow. A way to simplify the staging systems is to lump in stage 1 and 2 together. So lymph node and or spleen, those are intermediate risk. And then to lump in the patients who have low blood counts together, whether it's anemia, which is a low hemoglobin, or thrombocytopenia, a low platelet count, into the high risk category. And then low risk is patients who just have an elevated white blood cell count. So that gets you into 3 stages, either low, intermediate, or high risk. You may occasionally see Benet's staging system when you're doing your reading. We don't really use that in the US, but the gist of that is that it's a little bit different of a staging system that is divides up low risk and intermediate risk patients on whether or not they have under 3 involved nodal areas or more than 3. The high risk is still patients that have low blood counts. They use a different cutoff for the anemia of a hemoglobin under 10, whereas the US staging system uses a hemoglobin under 11. Another question that comes up a lot is, do I need a CT scan after I've been diagnosed? In medicine, there's a lot of tests that we can send, but there's a big question of, should we send every test that we can order? And there's a campaign based on the American Society of Hematology called the Choosing Wisely campaign that's trying to make us as doctors think a bit more about the tests we send and how is that going to then impact the patient either favorably or negatively. And so the recommendation from a number of years ago by Dr. John Bird, who's one of the most famous CLL doctors, he presented this recommendation to actually not perform baseline or routine CT scans in patients with CLL. This is in reference to asymptomatic patients. So if you have no symptoms at all, you ideally would not undergo a CT scan. The reason for that is CT scans don't make patients live any longer. It could expose patients to unnecessary radiation, and it can detect incidental findings that aren't necessarily related to the CLL at all. That could then lead to a lot of downstream testing, and all of our testing can lead to complications. Now, this doesn't mean there's not a role at all of CT scans in CLL. I do them, but I wait until patients have some type of symptom that I'm worried about, and then the CT actually does serve a purpose where it's doing workup for a symptom that I think could be related to the CLL. So I've talked about clinical staging, which we use the RISE staging most commonly in the United States. But what we know from these staging systems is that there are limitations. And so here are 4 hypothetical patients that I've based off patients that I've seen in my own practice. So one patient came into me with RISE stage 0, which should be the earliest stage, but he then progressed rapidly needing therapy. I have another patient who came in with swollen lymph nodes or maybe a slightly swollen spleen, but many, many years later did fine, ultimately needed therapy. I have another patient came in with RISE stage 3 disease. This is someone who's anemic. And so after some observation, making sure the anemia didn't have another cause, this person needed treatment. I have seen other patients like patient D who presents with RISE stage 4 disease, a low platelet count. That should be the worst disease as far as the clinical staging system. But I've actually seen many patients with platelets around 80 or 90 who are completely stable for years and years and years. And so these hypothetical patients I use as an example to let you know that the clinical staging is not perfect. We have some patients with what should be early stage disease that follow aggressive courses. We have some patients with high stage disease that follow very slow, boring courses. And so is there a way that we can better risk stratify our patients so they know what to expect, their family knows what to expect, and we know what to expect as doctors, meaning should we be monitoring them frequently, less frequently, et cetera. So moving into biomarkers. Biomarkers in general are markers that we can send through our testing that help us learn more about how a disease is going to behave in the future. These can be divided between prognostic biomarkers, which are those that forecast the natural progression of a disease with or without treatment and intervention. And so this can be used to stratify patients to help inform how often should we be following them, treatment decisions. And typically we measure these before treatment starts to help then have a better understanding of any individual's chance for long-term options. The other category of biomarkers are called predictive biomarkers. And so predictive biomarkers are the term that we use when a biomarker helps describe how a patient is expected to respond to any therapeutic regimen. And so this specifically isn't related just to the natural history, but it's related to the expected response upon exposure to a specific therapeutic regimen. So what are the important biomarkers in CLL? There are a few different categories. And so I imagine many of you have heard about the FISH test. This stands for fluorescent in situ hybridization. And all it is they use special fluorescent probes. A picture of that is in the bottom corner to see if certain common abnormalities in the DNA are present or absent. And what we've learned from large series of patients with CLL is that there are good findings and bad findings. The most favorable finding is to have a deletion in the long arm of the 13th chromosome. So chromosomes are just the big molecules that carry our DNA. They exist in every cell in our body, but we've seen that patients with CLL typically have one of 5 different patterns. And so to go through the 5 patterns that we see, I mentioned del13q is the most favorable. Trisomy 12, which just means you have an extra copy of the 12th chromosome, is considered intermediate, as is having just completely normal chromosomes. The historically poor risk findings were deletion in 11q, which is the long arm of the 11th chromosome. Those patients are actually doing a lot better nowadays, but that's considered unfavorable historically. And then the highest risk patients are patients that have a deletion in the short arm of the 17th chromosome. So that can be picked up 2 different ways. FISH testing is the most common way to test for this. I usually also send a karyotype, and so that will find these abnormalities, but it'll also find abnormalities that aren't included on the FISH panel. So the FISH panel is a pre-specified panel for things that are common in CLL, but sometimes you can find things that even are uncommon. Those can be picked up on the karyotype testing. So I think the tests are complementary, but the FISH is like a definite needed. Karyotype can also tell us if a patient has a complex karyotype. So if there are a lot of abnormalities, that has its own negative prognostic implications. So that's something I like to know. Another test is whether or not patients have TP53 mutations. A very common misunderstanding is that you'll find that on the FISH testing. The FISH testing picks up if there's a deletion in TP53. So TP53 is an extremely important gene in many cancer types, but also CLL, that lives on the 17th chromosome. So the FISH testing will pick up whether that gene is just completely deleted, it's gone. However, the gene can still be present, but it has a mutation, meaning a change in the DNA code. And so that's a separate test, and it's critical, in my view, to send that test before undergoing treatment, because that can impact how well a treatment may work. The next test that's also very important is the IGHV mutation status testing. Some large centers send this themselves. I historically have sent out my IGHV testing to the Mayo Clinic. It's a specialized test to assess for whether or not an individual with CLL has their immunoglobulin heavy chain mutated, which is actually the good finding, or unmutated, which is the unfavorable finding. And that has a significant impact on expected response to the therapies that we use. The last test that I send is something called the beta-2 microglobulin level. This is actually a pretty simple blood test. It's included in a large risk model that helps stratify patients, whether they're low risk, very high risk, called the CLL IPI or CLIPI. It stands for International Prognostic Model. So I also send that test. It's probably a little bit less important than all these other tests. And so another question is, well, can my markers change over time? And the answer to that is yes and no. So the IGHV mutation status, that does not change over time. So once you're mutated, you're always mutated. Once you're unmutated, you're always unmutated. However, the thing that can change is the cytogenetics and molecular tests. And so the patients, it's pretty uncommon to have 17p or TP53 mutation at first diagnosis. Maybe just 5 to 10% of individuals have that. However, after subsequent lines of therapy, these are more likely to emerge over time. And so this stresses the importance of repeated testing upon relapse disease when a new therapy is being considered, because if it wasn't present before, there is increased odds that it may arise with further time. And so our most important question, well, how do all these tests influence my outlook, my therapy selection? So a few key points. Number one, if a 17p deletion and or a TP53 mutation is present, patients should never receive what we refer to as cytotoxic chemotherapy. And this is regimens such as the FCR chemo regimen, the BR regimen, anything chlorambucil based. We don't really use a lot of these regimens nowadays at all because we have more effective novel agents, but absolutely, if you have these markers, you should not get chemo, these cytotoxic regimens. The reason is that they really don't work very well at all. So they either don't work at all to help the CLL, or it causes just a transient improvement and then it grows right back. And so you get none of the benefit with all of the toxicity. And these regimens are very toxic. In the historical days, the survival time with patients with these aberrations was pretty poor, on the order of 3 to 6 years, because all that was available were these chemos. And so, people with CLL that had it 10 years ago, we would use these chemos because we had no other options. And then the outlook was very poor. However, things are now very different. Thanks to the development of drugs that actually work extremely well, even in patients with these high-risk markers. And so I think that's been one of the most exciting advances in, the 13 years that I've now been doing CLL research and treating patients, that patients, even with these high-risk markers, can sustain many, many years with their disease under control and even in good remission. With the new therapies that are BTK inhibitors and venetoclax being the most commonly used. So the next point on how biomarkers can influence therapy selection. So if an individual has an unmutated IGHV, one should also not use cytotoxic chemo. It doesn't work as profoundly bad as when the 17p and TP53 mutation is present, but it still does not work very well. And so these patients would expect only short remissions, and it's just not worth getting an extremely toxic therapy if you're only going to be in remission a year or two. So we now preferentially use novel therapies like BTK inhibitors that actually work just as well in patients with unmutated, which is the bad finding, as the mutated patients. In patients with the mutated IGHV and no other unfavorable markers, one can occasionally consider this FCR chemo regimen if patients are young and fit. patients with this profile can sustain long-term remissions, like 10, 15 years, maybe around half of patients can get that. But most of us CLL experts still don't recommend that nowadays because there is a potential for long-term toxicities that can be permanent and even fatal. And so that's why most of us have completely stopped using FCR even in this subgroup, because a small percent of patients, maybe 2 to 5%, can develop secondary leukemia such as acute myeloid leukemia or myelodysplastic syndrome, which is often fatal. And the good thing is that, you know, FCR, sure, it works well, but it's so toxic. But patients with mutated IGHV actually have long remissions with honestly any therapy we give them. And so I favor the newer agents in this group as well, because they perform phenomenally well. So the CLL Society has an educational resource that I encourage you to familiarize yourself with if you're not already familiar, called Test Before Treat. And so what this emphasizes is the importance of testing these prognostic markers prior to treatment, because what you don't want to do is get a treatment that's going to cause you toxicity but not cause you a clinical benefit. And so it's really best to be informed on your risk profile. And so you can select in conjunction with your CLL provider, what is the best therapy for me, for my cancer, to get me the best response while minimizing unnecessary toxicity. And I love the slogan, which is smart patients get smart care. So there are some additional tests for disease monitoring and measurement. And one of the terms you'll hear a lot is MRD. This stands for, now we like to say measurable residual disease. They used to call it minimal residual disease, but I actually like the measurable term better. And this is a type of test that is commonly considered in individuals getting venetoclax-containing regimens. So the drugs work in different ways, but venetoclax is known to very effectively wipe out all CLL cells in the body. It's not curative, but it can kill off all detectable CLL, even to what I like to refer to as a needle in a haystack type level. And so these MRD tests are specialized tests to look for these very, very low levels of CLL. And what we know is that patients who are negative for MRD following these venetoclax-based regimens have a longer time until the cancer is ultimately going to progress, and they also live longer compared to patients who are detectable at the end of treatment. There are a number of different tests for MRD, and they have different limits of detection. So flow-based is what's been most commonly used. This is just a specialized flow cytometry assay to look for CLL cells. And so you have to count up, it counts up 10,000 different white blood cells. And if not a single one of those 10,000 cells is CLL, that would be considered negative. PCR is intermediate in its level of detection. And then the most sensitive test is this clonoSEQ test. It's a little bit more expensive, so I don't send it routinely, but it can detect actually a very, very low level of CLL. They count up 1 million white blood cells. And if not a single one of them is CLL, that's considered undetectable. So with that, I am really excited to hear your questions, and I thank you for your attention during this presentation on the role of these biomarkers in CLL. Thank you so much.
So we're going to now open it up to the audience Q&A. We received a lot of questions during the presentation, and we're going to try to get to as many of those as we can. If we do not answer your specific question, you can send a message to Ask the Expert at the CLL Society, and then that answer will be sent to you after it's answered by one of our experts. So the email address will be shared on the closing slide. So we want to thank everybody who did submit the questions first. Before, it does give us a little bit of time to review them and figure out exactly what questions we need to ask. So I'm just going to jump right in, Dr. Coombs. And here's one that says, does trisomy 12 complicate treatment?
I would say no. I mean, the prognostic factors, the main pieces of information that they give us are, number one is how is the CLL expected to behave, kind of as a measurement of how long it's going to take me to need therapy, if I need it at all. And then two, how well am I expected to respond to therapy if I do need it? But they don't lead to increased complications from therapy per se. So I wouldn't say it would complicate therapy. It just would help us know, are you going to need therapy at all? And then when you do need it, what's your expected response? Trisomy 12 is one of the intermediate findings. And so I would say the majority of patients with trisomy 12 have very good responses to therapy in my own experience, and what has been seen in other large groups and studies.
Okay, thank you. One of the tests that people ask about sometimes is IgG testing. Can you just explain what that is and what the results of that would mean to a patient?
Yeah, that is a great question. So I do send IgG testing in most patients, but it's not considered a prognostic or predictive biomarker. So let me just take a step back and explain why it is important in CLL. So we know that CLL patients are at increased risk for infections. The reason for that is pretty complicated, but one of the reasons is that about a third of patients with CLL, even when they haven't had therapy, are at risk of not making enough immunoglobulins. And so immunoglobulins are those proteins that our plasma cells make in order to fight off different infections that we may encounter in our day-to-day living. And so for reasons that aren't totally well understood, about 1 in 3 patients with CLL just doesn't make enough immunoglobulins. And so we can detect that by a blood test, and patients with low immunoglobulin levels may be more at risk for getting serious infections. There was a study, probably like 20 some years old, where they asked the question, for patients with low immunoglobulin levels that have had serious infections, meaning those that have led to hospitalization, is administering extra immunoglobulins through IVIG infusions beneficial? And the results of that study show that that can lead to a decrease in the risk of subsequent bacterial infections. So that is something that myself and many other CLL specialists and other, more broad hematologists and oncologists consider. However, it doesn't seem to have an independent predictive value on how the CLL is going to perform. So patients with these low levels at baseline aren't necessarily more likely to need treatment. And they're also not at risk of having a poor response to treatment whenever they get it. However, we do see the low immunoglobulin levels becoming more commonplace in patients who have had multiple lines of therapy, because many of the therapies that we use can also have a negative impact on the amount of immunoglobulins that patients produce.
Okay. This question might be a little bit dicey to answer, but are all oncologists aware of when to test and how to use biomarkers? I'll just add that in 2019, Dr. Anthony Mato did a study that showed that 33% of 17p patients and 42% of unmutated patients received chemotherapy, which is contrary to existing guidelines. Most, if not all, these patients were treated by local hematologists. What can we do to make sure patients get correct therapy based on their markers?
Well, gosh, Terry, I think you already answered my question for me with that study from Dr. Mato, who's a friend and a collaborator of mine. Yeah, I mean, I want to first go on the record to state that I think community hematologists and oncologists have an extremely, extremely hard job. They see not only CLL, but also a number of cancers that are 10 times as common as CLL that I know nothing about, colon cancer, breast cancer, day in and day out. And so, I think it's a very difficult job that they have, because CLL,
even though it's commonplace to me, it's like 90% of the patients that I see, it's not so commonplace to them because it's a small minority of the individuals that they see in any given week. So I think they have a tough job. But what we have seen through a number of real world collaborations, including the study that you cited by Dr. Mato, is that testing is underperformed, and even when testing is done, it's not interpreted correctly in that patients with certain markers that would then predict a very poor response to chemotherapy still get chemotherapy even when the markers are tested. And so I wish every CLL patient had access to a specialist. However, that's not always the case, and that could be because of geographical constraints. It could be because of insurance constraints. I do think in an ideal world, yes, every CLL patient would be able to meet with an expert who is uniquely focused on how important these tests are and how those can apply to not only the natural history of one's disease, but also apply it to the scenario of needing therapy and selecting the therapy that would offer the best benefit with the least opportunity for harm. I think it's a hard thing to, think, can I tell my oncologists, that they're wrong or that maybe they're missing something? But I mean, the slogan of the CLL Society, I think, is powerful. Smart patients get smart care. And I think any doctor that gets offended by you speaking up for yourself and advocating for yourself, I think that's a red flag. And none of us can know every single thing. And so I learn a lot from my patients. And I think, most doctors would be receptive to, you advocating for yourself if something seems amiss. I think a lot of the community docs that I work with and refer are always happy to hear expertise, because I don't think anyone thinks that they can know everything. I think it's, nearly impossible in our day and age. So I wouldn't be afraid to advocate for yourself. And if something seems amiss, or if you have a doctor who's just not receptive to your feedback, I think that's a red flag. And I think it's always okay to get a second opinion. I never get offended when my patients ask for second opinions. And that, of course, is something that comes up sometimes. Sometimes there are very complicated cases. And so those are just my pearls of wisdom regarding that question.
But I would assume you can say that the patient should ask if these tests have been run by their doctor, especially before treatment, right?
Absolutely. Yeah. So I think, there's some legislation where test results have to be made available. And so that's your right to get your test results. And if they haven't been done, or if you're not aware if they've been done, absolutely ask, especially before treatment. It's just so critical to know what your markers are, because then you'll know, what are my odds of responding, and make sure I'm not getting some type of therapy that's not going to benefit me. But then I, get all the side effects, because that is, I think, really unfair and something we want to avoid.
Okay. There's historical data that shows that patients with certain markers don't respond to chemotherapy, or have a very short response. But is there any data that's being collected that shows that what a patient with either 17p or 11q or unmutated, how they respond with the new treatments like BTK inhibitors or BCL2 inhibitors?
Yeah, that data has been collected. And so 11q deletions, those historically, and when I say historically, I'm talking about the kind of IV chemotherapy days, a decade ago plus. Patients who have 11q deletion, their response is nearly identical to patients without 11q deletion. So I almost don't even think of that as a negative prognostic marker in our kind of modern era. That's especially the case with the BTK inhibitors. 17p patients do still have the least favorable outlook, but the difference between having 17p and not, it's narrowing. And so in the olden days, the survival used to be much, much, much shorter when one had a 17p deletion. Now, the responses still aren't probably quite as long-lived, but they're a lot closer, especially with the use of continuous BTK inhibitors, such as ibrutinib being the first approved. And nowadays, many of us, myself included, are using the newer generation BTK inhibitors like acalabrutinib and zanubrutinib because they have improved safety profiles. And so there's probably a slight difference, but maybe not so much at all. And so these new drugs work just as well in the setting of the BTK inhibitor class. Now, it is a little bit different of a story when we're talking about venetoclax and obinutuzumab regimen. That regimen is a time-limited regimen where patients are only on therapy a year, and individuals with the 17p deletion that received that regimen did appear to have a significantly shorter time until progression as compared to those patients without the abnormality. But it actually still does work, and it works way better than the old chemo used to work. And so patients that got that regimen don't progress until about 4 years later, even with this high-risk marker, and then potentially they can still be retreated when they relapse. But patients without that marker, their time until they progress is probably quite a bit longer, like 6, 7+ years. We're still waiting for longer follow-up to know exactly what the median is, which median is similar to an average, but a little different statistically.
Okay. You mentioned that some biomarkers don't change or usually don't change, but some do change. So the question is, why do they change? Is it because of the treatment or is it because of the CLL that they change?
That's a good question. I think it is. So the marker that does not change is the IGHV. I test that at diagnosis, and then it's not recommended to repeat it because it's supposed to remain static over the course of the disease's lifetime. The markers that do change are the 17p deletion. The other cytogenetic markers can evolve over time, and then TP53 mutation can change over time. As far as why it changes, I would say it's more a function of treatment. But some diseases, CLL included, can also, naturally evolve. But I would say it's more a factor of treatment, because what we know is that in patients at diagnosis, the 17p or TP53 mutation is pretty uncommon. Maybe only around 5 to 10% of individuals have that marker. But with every subsequent line of therapy, that marker then kind of becomes enriched. And so if there's a study where patients have had 3, 4 lines of prior therapy, we can find the 17p deletion or the TP53 mutation in, like 50% of patients. I know it has been reported that these abnormalities can arise with time and absence of therapy, but I think that's a lot less common. In my own practice, I usually don't repeat the markers just routinely. Like, say someone's diagnosed, I don't know, in like 2016, and then I don't just repeat them at 2017 if they're still on watch and wait. If it's been like 10 years that I've had someone on watchful waiting, I might repeat them if they finally need treatment, because perhaps a change could arise, but I would say that's a lot less common than the common scenario, which is the adverse markers, if not present early on, can arise after, multiple lines of therapy. And as far as the why goes, I mean, it kind of gets down to how treatment actually works. And I think we know a lot more about chemotherapy, so kind of these regimens that are now a bit outdated, but the 17p and TP53 in particular are very, very resistant to chemotherapy. And so the reason that those arise over time with subsequent lines of therapy is that they may have been there all along at a tiny, tiny, tiny low level that was just kind of lingering in the background. But then when you expose that population of CLL cells to chemo, these cells just don't die with chemo. And if anything, they, get kind of a survival advantage because all the other CLL cells do die. And then the really nasty ones now have this ability to kind of be the weeds that outgrow the garden, so to speak. I don't think we know quite as much about clonal evolution in the setting of novel therapies. I think that's information that we're going to get, with more subsequent years of follow-up. But that would be the best why that I can provide.
Okay. Is there any advantage of checking for changes in biomarkers while you're in treatment itself, other than MRD testing?
Yeah, so the MRD is kind of its own category. As far as finding the biomarkers, I usually wouldn't test them during therapy unless someone was having a less than optimal response and I was worried that he or she might be progressing. But otherwise, my own practice is once we've picked a therapy, let's just see it through. And, like almost all of our therapies work in the great majority of patients. So if the therapy is working and the patient is tolerating it, I personally would not retest. However, if it's in one of these rare cases where it looks like maybe it's not working the way we hope, I think we always could, retest for mutations. But in general, I wouldn't do that routinely.
Okay. Here's one that may be a little bit deep, but is it still believed that the 321 gene usage cancels the benefit of mutated IGHV?
Oh, yeah. Yeah, that's kind of a high level question. So the IGHV, the simple way of looking at the result is either you're mutated or unmutated. And I think I saw another question in the chat that relates to the mutation cutoff. And so when they do the test, they take a look to see, well, how mutated are you? And kind of probably the more mutated, the better, but that's a little too confusing. And we have to just define cutoffs to be able to use tests and then apply it. And so it's 2%, that's the cutoff. So most of us say under 2%, you're unmutated, more than 2%, you're mutated. And, it's good to be mutated. However, there's different, they call them stereotypes. So there's a lot of different families of IGHV rearrangements that can be detected that interestingly just kind of recur in years and years of studying CLL patients. They're not related, but they different patients who are unrelated develop very similar rearrangements, and some are good, some are bad. But the 321 rearrangement, in fact, is one that is unique in that even if it's unmutated, or even if it's mutated, it is still thought to behave kind of poorly in that it behaves more like an unmutated. And that detail is kind of graduate level CLL work, but it is something that's borne out in studies. So I recently saw a big study looking at CLL, and they specifically lump those patients with the unmutated because they do kind of track a little bit better with that group. But as far as whether that applies with, just that one study or all studies, I haven't seen that level of detail with every clinical study.
Okay.
But yeah.
This is one that people always worry about is how are these tests administered? Because people are always worried about, oh, do I have to have a bone marrow biopsy or is it some invasive test? But for most of the tests, how are they actually administered?
Yeah, so for the run of the mill CLL patient, these are just blood tests. And so that is one really great thing, is that it's no more invasive than just any other routine blood tests. There are a couple exceptions to that rule. And so I saw a question in the chat about, I have SLL, is this the same for me? And the answer to that question is it kind of depends. I'd say most of my SLL patients have some blood component. It's just not a lot. And so it kind of depends on how sensitive the test is, whether or not it'd be able to pick up the amount of circulating cells and then yield a result or not. Most of the time the test will say, insignificant amount of cancer cells, we can't give you a result. And I have had patients with SLL that I had to do a lymph node biopsy and do the testing because there just was like no blood involvement or such a scant amount of blood involvement that they couldn't run the tests on the blood. I typically don't feel that bone marrows are needed to run these testings. It doesn't mean that bone marrows are never indicated, but to get the tests, I send them from the blood just because that's the easiest place to get it, and the test can take a few weeks to come back. I've had even a very rare CLL patient with CLL. You're supposed to have a significant amount of disease in the blood, but I've even had like 1 or 2 patients, just because I see a lot of CLL, that had almost no blood involvement, that we did a marrow just to get, you have to find where the disease actually is. And so most patients it's in the blood, but there are these rare scenarios where the blood is devoid of the cells, or there's just such a tiny level that the tests just aren't able to pick up the really low level. But that's the minority of cases, but it does apply to some SLL patients.
Okay. I think this one comes out of a next generation gene sequencing test. What are SFB3 and POT1, and are they relevant to CLL? When would you actually, number one, when would you actually see that type of data? And I guess, are they relevant to CLL?
Yeah, so these are 2 other mutations. So they would be picked up on similar tests that would be used to detect the TP53 mutation. I'll say in 2023, the TP53 is the only one that I think needs to be done routinely, because the data and our prognostic knowledge is highly dependent on the results of that mutation test. However, there have been studies looking at the impact of other mutations, and some centers have tests that pick up not only the TP53, but a lot of these other genes. And so I think we probably will learn more about the impact of some other gene mutations. SF3B1 is known to lead to poorer outcomes, but it's not as well established at doing that as TP53. And so it may or may not be worth testing. And I think if we lived in a society that had no limitation to its resources, I would certainly be happy to test for it, and maybe we'd learn more over time. But sometimes by adding on these extra genes, that really increases the cost of testing. And so if your own institution just has a panel that happens to test for these, I'm not opposed to it, but I wouldn't specifically test for it if it added any cost to the patient, because the implication is a little less clear. And POT1, I know even less about. I actually looked that one up. But yeah, apparently it can be one that people are either born with, or it can be one that's acquired over time. And I think that's something very important to just talk about with mutations in general. Most mutations that we talk about are things that are acquired, meaning that you're not born with, and therefore that you would not directly pass on to your family. But the POT1 apparently is one that you can be born with, but I've never encountered that in my own clinical practice. I've just seen a few papers related to it. But I would say its impact is maybe not fully clear, and it's not considered a routine test, but that may change with more years of research.
Yeah. I know that in my support group, I do recommend patients ask if their insurance covers this test before they actually just ask for it, because it can be thousands of dollars and the insurance company might not pay for it. So you should know that going into asking for this test. So, I think you talked about this a little bit, but the accuracy of the IGHV test, and I mean, I know there might be chances for error, and I know people that have been, told they were mutated, and then it turns out that they were unmutated. But do you think in this day and age, there is a high likelihood that this test would be wrong on its initial, observation? Or do you think generally now that the test is pretty accurate no matter where you get it?
Yeah, I mean, so that's interesting. Like 10 years ago, it was pretty hard to do this test, and they instead were using some of these other prognostic markers, such as the ZAP70 and the CD38 as surrogates, just because the test was not widely available and it wasn't reproducible. That I would say is different now. And so I think when I get a result, I find that it's very reliable, but maybe like 1 out of 20 patients. I don't know, that's a rough estimate, but infrequently I have had patients that they just can't get a result. And this, I usually send mine to the Mayo Clinic. There's another lab that's a little bit more used on the West Coast called Erupt. But anyway, so there's these specialized labs that do the test, and sometimes for kind of technical reasons, they just can't get a sequence, and it probably has something to do with the intrinsic properties of the CLL. And those patients are just called indeterminate, meaning neither mutated or unmutated. And that is something that I've seen rarely. I can only think of a few cases, so probably more like 1 out of 50 patients. And that I've actually even sent out to a couple different labs, and in fact, some just can't be performed. So the ones that are indeterminate, I just let it be. I think we're not going to get a result, and it's probably not the lab's fault so much as the actual sequence in the patient is one that can't readily get a result. But when I do get a result, I found that to be reproducible.
Okay. Do you know of any studies that have actually talked about overall survival times based on having particular markers?
Yeah, so the one that led to us all doing the FISH testing and looking for these cytogenetics showed the survival time based on whether or not individuals had the 17p deletion versus the 11q, and then all the way to the most favorable finding of the 13q, and showed much longer survival times for people with the 13q as a sole abnormality, and the shortest survival times for the individuals with the 17p abnormality. And then there was another study showing the same thing for the mutated versus unmutated IGHV. So yeah, we definitely have these studies showing that these findings correlate with survival. But with any study that looks at a marker and looks at its impact on survival, these studies always somewhat lag from the present, because you have to study a group of patients for 10 plus years with a disease like CLL that is chronic in nature. People aren't dying right away. It takes many years to die, if you ever die from the disease. Everybody dies eventually of something. And so what I'm trying to say is the studies back then aren't that accurate now, because we did not have access to the therapies we have now based on this group of patients that are now 20 years ago. And so I always just ask my patients to have some calmness when they look at survival numbers, because they don't reflect today, and today is better. And I just know that for a fact. And I think there have been population-based studies to show, gosh, people with CLL are living longer and longer, but it doesn't take away the fact that when you Google, oh, what's my survival, you'll get a result from one of these studies, but every study is outdated because of the amount of time it takes to follow people to get these survival numbers. And those patients back then are never going to have access to what you have now. And we've had an extraordinary amount of drugs approved in CLL that really have changed the outlook for the better. So it's hard not to get discouraged when you see these numbers, but I'd say none of them are ever really that accurate, because we can never just keep up with the science, but you can never follow people into the future without those patients that were part of the original study now being part of the past.
Yeah. In your slide presentation, you had the 4-patient example. And would you ever suggest for patients see measures to cope with the anemia, injections to postpone the CLL therapy? And isn't it important to determine the reason for the anemia is really the key, isn't it?
Yeah. So I'd say most patients with anemia, if I'm convinced it's from the CLL, I do end up treating the CLL itself. But I've had a lot of where it's either just completely unrelated to the CLL, which I always check. So like iron deficiency has come up a lot, B12 deficiency, some other exotic cause of anemia. And then, you just fix whatever the nutritional issue is, and it's not due to the CLL at all. Or it could be the special scenario of an autoimmune hemolytic anemia, which also can cause low platelets. And these autoimmune cytopenias. So whether it's autoimmune hemolytic anemia or ITP, which is when the platelets get damaged by this abnormal immune response, those are pretty common in people with CLL. Maybe like 10 to 15% of CLL patients with CLL can be afflicted with that over the course of their disease. Those, technically speaking, aren't supposed to get you into the increased RI stage. And so if I have someone with an isolated autoimmune hemolytic anemia, I don't treat the CLL, I treat the immune response. And usually that's just with steroids.
Right.
But steroids aren't a good long-term solution. And so sometimes, I might do like 4, rounds of rituximab, which I've had like just put the anemia at bay for like a long period of time, like years and years. And then we don't actually have to treat the underlying CLL. So the staging is meant to exclude patients with anemia due to other causes, including anemia due to autoimmunity, even if it's indirectly related to the CLL. That being said, there are cases of patients with CLL that don't really respond as long or as well as we would hope to our treatments for the autoimmunity, in which case persistence of the autoimmune cytopenia is a reason to treat the underlying CLL if it's not successful doing the other treatments, which comes up sometimes.
Right. Talking about RI staging, is there a minimum size of an enlarged lymph node to qualify for stage 2?
Yeah, it's 1.5 centimeters. So that's not that big. And, but yeah, that's the size that we measure in CLL. Under 1.5 is considered normal. It's like a little less than an inch above that's considered enlarged. But, with the RI staging system, it also is supposed to be a lymph node that's palpable by physical exam. And so I've had patients get scans, even though I wouldn't routinely do a scan for an asymptomatic patient. But, sometimes they just get scans by their doctor. It picks up some tiny, lymph node deep in the abdomen. That, technically speaking, shouldn't get you into an advanced RI staging. The intention and the way that the staging was developed and validated is based on the lymph nodes that are big enough to feel by physical exam. And so these are the ones in the neck, the underarm, the groin, the ones deep inside the chest or the belly. Technically speaking, shouldn't get you into the right staging system, because you can find slightly enlarged lymph nodes there, but those ones aren't. Those ones haven't been proven to lead to the higher staging outcomes, whether it's with respect to progressing or, the overall survival.
This one comes up all the time because it shows up in tests and people are really worried about it. When they get the test results back, they show something that says they have smudge cells and they get all nervous about having those. Could you please explain what those are and why they appear on the test?
Yeah. So smudge cells are just the word for the abnormal appearance of a blood cell when it's reviewed under the microscope. And smudge just means it's kind of busted up. And it's not specific to CLL, but CLL cells often smudge, meaning when they go onto the glass slide that someone then looks at under the microscope, they're fragile in that setting and they kind of bust open. And so smudge cells are not anything to be worried about. They happen in almost all CLL patients. But, if you have a smudge cell, it's not always from CLL, but if you have CLL, it's probably the cause of your smudge cell. But I've had other patients kind of get referred to me with smudge cells, and it can happen with other blood cancers. It can even happen occasionally with normal blood cells, just if it's like a technical issue that is nothing to be scared of.
Okay. All right. I'm going to ask one because we had a couple of people ask this question, and I know it does show up on some of the test results. And the flow cytometry result shows atypical kappa population of dual monoclonal population, kappa lambda 2:1. So what does that mean?
Oh boy. Okay. So CLL should be kappa or lambda. I have had some patients that happen to have 2 different CLLs, and that's one way that you could get a kappa and lambda. I've also had patients who are both mutated and unmutated because you somehow simultaneously, or maybe not simultaneously, but maybe 1 year this B cell turned into a kappa CLL. And then, 2 years later, this one turned into a lambda CLL, and that one's mutated, this one's unmutated. So some people can have 2 different CLLs, and that's, that's unusual. I've seen that more than one time. So that would be the most likely reason I would see someone with a kappa and lambda is they actually have 2 different types of CLL. It could be that you have a different type of blood cancer, or it could be, everyone has some degree of kappa and lambda. And so I'd have to probably look at the report to say, oh, is this something that clearly looks like a cancerous clonal population, whether it's 2 CLLs or 1 CLL with the kappa. And then I had, another patient who had like a Waldenstrom's with the lambda, like just other types of, chronic blood cancers.
So you'd really need to see the full report.
I'd have to see the report. But the other thing is you can check the free kappa and lambda, which just floats around in your blood. So everyone has some degree of kappa and lambda. And that's just a byproduct of our B cell development. So if it's the level of the kappa and lambda just in the blood, everyone has some, and the levels of both can go up, especially in the setting of chronic kidney disease. But if it's a flow report with 1 kappa population and 1 lambda population, that's more worrying for 2 distinct cancers, whether it's 2 CLLs in 1 person, which is weird, but I've definitely seen it a few times. Or, but yeah, I'd have to see the report. Yeah.
Okay. I know when I was first tested for these, they did a ZAP70 test. And at the time I was warned that the accuracy of that result is really a direct relationship to the lab that it's done, and not a lot of people did it accurately. But I noticed lately that ZAP70 has not come up much in terms of the tests that they run. Is ZAP70 still a good test to run? Does it really have any clinical significance?
I would say it's only significant in the setting of a patient who is unable to access IGHV testing. It purely is a surrogate for the IGHV test. And it was never that good of a surrogate for the reasons that you state, which is that it actually was a very hard test to get an accurate result. But it was a way to replace IGHV when IGHV wasn't widely available, even though it didn't do a great job of that. Now that IGHV is available, I never send it. So it was a surrogate for the IGHV test, which actually itself is a more reliable test and a better predictor of outcomes. So yeah, ZAP70's kind of gone by the wayside now that we have reliable and predictable IGHV testing pretty broadly.
Okay. I think we've covered this a little bit, but what is the prognostic or outcome from therapy progression for unmutated with a BCL2 or a BTK? Would the remission time be shorter for an 11q patient?
11q, I have seen the data that it does like pretty much exactly as well with a BTK inhibitor. I don't know if I've seen the data as far as a venetoclax BCL2 based approach for 11q. But what I know I've seen with the ven-oben regimen is the difference in progression-free survival for 2 other particular risk groups. The one I had already mentioned is individuals with 17p deletion do have the shortest remissions following venetoclax and obinutuzumab. In my view, it's still way better than we ever had in the past with the time-limited regimen. And so it's 49 months, so a little over 4 years until someone progresses with 17p that gets ven-oben. The caveat is it's not that many patients. I think it was only like 23, 25 from the study that led to the ven-oben regimen getting its FDA approval. But anyway, that's still a decent remission, but not as good as if you were to be on a BTK inhibitor continuously. The other subgroup that I have seen from the ven-oben regimen is the unmutated IGHV patients. And so the mutated IGHV patients just do phenomenally well, honestly, with any therapy they get, but especially with ven-oben, very few have progressed in the amount of time that we've been following folks that first got this regimen, which is 5+ years now. On the contrary, the unmutated patients do have shorter remissions. I think it's right around 58 months, so just under 5 years. And by remission, I mean that's the time until the cancer progresses, is just under 5 years for the unmutated. But because it's a time-limited regimen, I do look at these periods of time until progression and kind of with a unique lens, because you can still retreat with venetoclax, and we're getting more information on how that goes. It usually leads to responses in the majority of patients. And so it's just kind of a different way of treating CLL. So the BTK inhibitors we call treat to progression therapies, where you're on it, and as long as you're tolerating it and the cancer's not progressing, you just stay on it. But then once the cancer progresses, another BTK inhibitor isn't going to work, as far as, kind of the currently FDA approved BTK inhibitors in CLL. There is this new one for kind of people that are super in tune with the news called pirtobrutinib that will work, but that's currently not approved for CLL. It's only approved for mantle cell lymphoma, but that works, that targets BTK in a different fashion.
Right.
Anyway, so I kind of went off on a tangent, but I like the time-limited regimen kind of philosophically. You go on something for a year, you get a break, and whenever the disease comes back, you could either just hit it with the old thing, especially if you had a good response, hit it with the ven again, or switch to a different class, meaning a BTK inhibitor. Whereas, you can't really do that if you progress while you're on a therapy. The similar drug is already proven it's not working anymore.
Right. I think somebody put in the chat that they had mentioned venetoclax for 6-month treatment, but isn't venetoclax usually at least a year, 12 months?
Yeah, I saw that in the chat, and I think the response was related to someone who had his or her MRD checked at 6 months. So in my own clinic, I do check the MRD before the end of therapy, and if someone's negative, then I say, awesome, we're negative, and let's just finish out the year. But I wouldn't shorten the year time, but I might check the MRD earlier, and that to me says you're having a good response, but I wouldn't shorten the therapy. I did have a clinical trial, actually, is Anthony Mado's study open back when I was faculty at UNC, that was testing the question, can we stop therapy early? And it would allow patients in the context of a clinical trial to stop after 9 months if they got like super negative MRD, which was by the clonoSEQ test, that test to the really, really low level of 1 out of 1 million. But that's considered experimental. I would always do the full year, except, if you were on a well-monitored clinical trial.
Yeah. Okay, here's one. What does polyclonal mean?
Oh, okay. So this may even go back to our kappa lambda conversation. So with CLL, this is considered a clone, and that means the word clone means that all of the cells look exactly the same. So a CLL patient is going to either have kappa or lambda, not both, and that's monoclonal, mono meaning one clone. Polyclonal is the word used when there's more than one clone. And so if you ever have a test result that says polyclonal, it means it's probably not cancerous in the setting of whatever it was testing. Or there could be more than one clone, but usually then they would say biclonal as opposed to polyclonal. I'd have to see the report to know that for sure, but that in general, polyclonal is like many clones.
Right. Okay. Here's more of a general question, but has there been any studies that show that CLL, SLL is hereditary? Yeah,
that actually was one of the very first things that got me into CLL. Like when I graduated med school in 2010, the person I did research with at Duke when I was a resident was really interested in familial CLL. So I had followed that literature actually for a long time. It's more likely to run in families than most blood cancers. However, that is still the minority of cases. In patients with familial CLL, we would only call it familial as if there was like more than one afflicted family member. And so I always ask my new CLL patients if there's any family history of CLL. And if there is, or sometimes it's CLL and just other lymphomas, there can be these clusters of lymphomas in any given family, which could just be all CLL, or it could be other non-Hodgkin lymphomas. So it's of interest, but the problem is there's no routine clinical tests to then act on this. So it's all considered research-based. What they found through research, which are not available tests for the community, is that there are certain genes, like polymorphisms, that can increase a family's risk of CLL, and it's through the acquisition of just kind of these different markers. They're not clearly causative, and so some of this may just be associations. It's not like breast cancer, for example, where, you know, mom had breast cancer because she had a mutation in the BRCA1 or 2 gene, and then she passes that to her daughter, who's then at way high risk. These are very modest increase in the risk, and they're not single genes. So it's usually a clustering of these polymorphisms that then increase the risk, but none of them are able to be widely tested. I think there also is not really consensus on what to tell families that are affected with multiple CLL. You know, in contrast to a lot of cancers, there's not really a huge benefit of early detection of CLL. And so I do think it does create some anxiety to try to pick it up earlier, given that, you know, our approach with someone with no symptoms is usually watchful waiting. Obviously, we have clinical trials asking the question, could early therapy be beneficial? None of those trials have yet panned out, but, you know, I think things may be different with our future trials because our drugs are so much better. So I do have mixed feelings. You know, I think it just depends on, you know, what's important to the person. If your family members are the type that really want to know everything, I think it could be an individualized discussion with their doctor to say, hey, you know, I have multiple family members with CLL. Should I, you know, consider getting blood counts checked at an earlier age? But there's no wide recommendation, and it's not something directly passed on. But if you have clustering of CLL in multiple of your family members, it, you know, is likely that you are one of these less common, but, you know, it's something I've seen, you know, many times, cases where it's a familial CLL. Most studies of familial CLL have shown that it's not higher risk. If anything, some familial cases may be like less aggressive. I did see one recent report that showed, oh, it is more aggressive. And so that's been conflicting, but I'd say in general, the familial cases don't seem to behave any more negatively from most reports I've seen.
Okay. You answered this in the slide presentation, but I think it's important enough to review again. And the question was, when chemo is not appropriate, is there a test to determine what the best novel treatment is?
Yeah, so chemo is not appropriate when someone has 17p, TP53 mutation, or unmutated IGHV. And if someone is mutated with no other unfavorable markers, chemo can be considered, but most of us still shy away from it because it can have long-term permanent toxicities. As far as what tests then would point to which novel therapy is the best, you know, there are a lot of CLL experts that say they prefer BTK inhibitors for individuals with 17p and TP53 mutation. And I actually still think you can use Ven-Oben if you're aware of the limitations of that regimen, which is that it will lead probably to a shorter remission than if you were to be on a continuous BTK inhibitor. But, you know, some patients have a goal to be off therapy to, you know, maybe go traveling or, you know, have a break. And I think all of our novel therapies work well, even in our highest risk patients. The BTK inhibitors are the drugs that are likely to lead to the longest time until progression, but they are continuous therapies. And so I do usually lean towards those for those high risk patients, but I don't think it's wrong to do a time limited regimen with appropriate counseling. Was that the right question, or were you asking something else?
Yeah. Actually, it was kind of two parts, I think, you know, that they say that chemotherapy is really not indicated usually for patients with CLL now, just because of the long-term effects. So, yeah, so I think you did answer in terms of pointing, you know, I mean, you're talking about long-term continuous therapy or a fixed duration treatment. And really it sometimes is patient choice, right?
I think there is a lot of choice. So we have, I'd say our two competing regimens for our first therapy are either continuous BTK inhibitors or then with obinutuzumab. And we don't have any head-to-head studies saying which one of these is better. What we know is that they both work really well, but they're very different. And so I think it's almost always an individualized discussion. There are occasional situations where one of those wouldn't be a good match for a given patient, given their access to care, access to labs for monitoring, comorbidities, et cetera. But in general, I think they both work really well. I haven't used chemotherapy in over 5 years. So in theory, yes, it could be considered, but most of us don't consider it because of how toxic it is and how it doesn't, it works really well in this small subgroup of patients with the mutated and no other favorable markers, and you have to be young and fit. But the other regimens also work really well and they're less toxic. So that's why I don't use the old chemo anymore. It worked, but we have better things now.
Right. This is an interesting question. It says, any research on how CLL progresses and which treatment are more effective for men versus women?
Oh, you might, I'm not as up to date on that. I don't think I've seen much on differences in sexes, but I can't say that I haven't, that a study hasn't escaped my notice. So I'm going to say good question. And that's one I'm going to have to look up.
Right. Okay, here's one that's a little bit more technical. What about translocation T1418, also CD38 and ZAP70, positive or negative?
I think with that, I might have to see the path report because, some translocations do make me worry. Could it be a different type of lymphoma? So that one, I probably want to look at the actual report to be confident it's CLL as opposed to, a different type of lymphoid malignancy.
Right. Okay. Let's see here. Is there any significance to having biallelic deletion of 13q and 14p?
I've seen a little bit of mixed results on that, but I would say my general view based on kind of the totality of all the studies I've seen is that it's not bad and it might be good. And it's always good to have 13q, but to have biallelic, I'm not convinced it's much different than having monoallelic, but there has been some mixed results, but probably good.
Okay. Let's see. We've got some just more general questions that aren't specific to that, but I think we can throw those out there. Are there de facto markers that inform treatment decisions? For example, skin eruptions.
Oh, I've had a few cases of unusual CLL that I've treated based on occasionally extensive skin involvement. That's uncommon. Also kidney involvement, central nervous system involvement. So these are, more exceptions than the rules, but one can consider treating the CLL for kind of any of these, we say extranodal sites of disease. So for skin involvement, I think it's paramount importance to get a skin biopsy with expert review and feel really confident, yes, this is definitely the CLL causing the eruption, as opposed to a lot of biopsies, the CLL cells can kind of just be bystanders. And so you kind of have to really know what you're looking at to know, is this definitely the CLL, or was the CLL kind of just along for the ride, so to speak? And, maybe this is a different type of rash, or, we know CLL patients are also at increased risk for skin cancer. I've heard some opinions that for a significant amount of extranodal disease, meaning, it's not the blood, marrow, or, lymph nodes or spleen, that some docs prefer the BTK inhibitors. I don't think the data are great for that. I think the venetoclax regimen and obinutuzumab might also work really well. Because these are so rare, we don't have robust data to support these, but I think probably both regimens would work.
Specifically, it was eosinophilic dermatosis of hematological malignancy. That was the diagnosis.
You know, I think I'd have to really look into that case a bit more detail, because eosinophilic, that sometimes points to allergy, but that can be associated with malignancies. I don't know if I've seen that in association with CLL. Not saying that it's impossible, but I'd probably want to delve into that a bit more before providing, you know, a firm recommendation, because that's a bit more unusual.
Could that also be related to extremely low IgG level or immunoglobulin levels as well? Is that something that could?
Yeah, I've not seen that. I mean, the low immunoglobulin level is primarily predisposed to infections. These kind of allergic type responses, the eosinophils sometimes are associated with an increase in the IgE, which that one's usually not as affected by the CLL. That's usually more the IgG, IgA, and IgM. I think it's hard to render an answer as far as this one.
Yeah. I mean, you touched on it a little bit, but you know, I read some studies that said that CLL patients are 8 times more susceptible to skin cancers than the general population. Can you explain why that would be for us? Is it just because we have this wonky immune system that is unable to fight things off? But
I think that's the main reason. Yeah, I think if we all had perfect immune systems, none of us would get cancer or infections. And we know CLL affected patients have a degree of immune dysfunction, and that immune dysfunction increases the risk for all other cancers, but the one that's the most significant is the skin cancer risk. And so I recommend my patients see dermatologists at least once a year for a full skin check. You know, some of it may be the demographics of CLL. It is more common in Caucasian individuals, which are more prone to skin cancer anyway, due to the low amount of melanin. So, you know, there's probably a little bit more to it, but I think the immune dysfunction is the number-one culprit.
okay. You know, we're reaching the end of our time, and I want to make sure if you have any closing thoughts, Dr. Coombs, that you can present them. I'll let you kind of start to wrap it up here.
Okay, well, Terry, it was great to do this panel with you, and such an honor to be able to speak to so many of you. I hope we tackled most of your questions. I know I could see a ton coming up through the chat, and so I'm sorry if we missed any. I am really just in a fortunate position to be able to care for individuals with CLL. I think the time is wonderful in that we no longer need to be scared. Even when we have these poor prognostic markers, our therapies in the past 5 to 10 years that have been developed have shown huge efficacy, even in patients that we historically considered hard to treat. There are always options and always more on the horizon. And so I think the future is bright, and I always think of it as an honor to serve your community.
Well, thank you very much for joining us today. And once again, I'd like to thank our generous donors and grant support from AstraZeneca for making this event possible through their support. And I want to thank all of you for joining us today. I know that we didn't get to all the questions, but if you still have a question that you would like answered, you can email that to asktheexpert, all one word, at cllsociety.org. We'd also like you to fill out the post-event survey, because your feedback is important to us to make these events more meaningful to the CLL patients. Before the event, we had a lot of questions that were submitted that were specifically related to COVID, and to help answer those questions, which we will track and we will keep in our files. But on June the 27th, there's going to be a webinar specific to COVID-19. And so you can really look forward to that coming up, and ask, actually, there'll be a place where you can ask more questions as well before that event happens. So please remember that the CLL Society is invested in your long life. Please invest in the long life of the CLL Society by supporting our work. So thank you very much for joining us today, and I hope the information that was put out today helped you get through your journey. Thank you.
Thank you.